Good afternoon and welcome everyone. On behalf of Maple Inc., we're pleased to present the webinar entitled Beyond Bias, Advancing Obesity Treatment Coverage for Enhanced Patient Care, sponsored by Obesity Matters, with support from Bosch Health, Novo Nordisk, and Desjardins Insurance. This event is part of Maple Incorporated's ongoing webinar series for education in healthcare policy and pharmaceutical product coverage in Canada. Those of you who've registered in the past will be familiar with the format of these events. Maple is a consulting firm that works with all stakeholders in the private payer market for issues pertaining to pharmaceuticals within plan sponsor health benefits plans. My name is Alison Garwood-Jones. I'm your facilitator today, and I'm joining you from Toronto, Ontario. Today's webinar will qualify you for one continuing education credit from the Institute for Advanced Financial Education. At this time, we'd like to welcome our attendees who are representing almost all provinces across Canada. These webinars are offered by invitation only and are held for private viewing. So thank you so much, everyone, for taking the time to join us today. Before we get started, just a bit of housekeeping. We kindly ask that you close any non-essential programs that are still open on your computer. Doing that will help ensure that the quality of the sound and the video on your computer remains constant throughout the webinar. Today's session will be approximately 60 minutes long, and our webinar platform allows you to move and resize the various panels that you see on your screen. So if you want to make the slides panel, the links panel, or the video panel bigger or smaller, you can do that with your mouse. And if you want to go back to the default view, just click on the Restore button, which you'll find as the first icon located along the bottom of your screen. Today, you'll have the opportunity to ask questions using the Q&A panel on your screen. Just type in your question and click Submit, and we'll defer the questions until the final segment of the webinar. You can also reach us via the Q&A panel if you experience any technical difficulties during the broadcast today. Our team is here to support you. Polling questions are going to appear throughout the session to gauge your understanding and opinions on today's subject. So as a requirement for CE credits, we ask that you respond to each polling question. The polling questions will not be knowledge-based. Only your polling participation throughout the 60-minute webinar is needed to qualify for the CE credit. The polling questions will appear in the slides panel, and I'll read the question. Then we ask that you select your answer using your mouse or your touchpad and click Submit. You'll have about 10 seconds to respond to each polling question. The responses will then be tabulated and aggregated and appear on your screen, and we'll review them together after each question. Rest assured that your individual responses to our polling questions will remain anonymous. Additionally, please be sure to stay to the end of the webinar, as a brief survey is going to pop up on your screen just as we're adjourning. So please let us know if you require a CE certificate in this feedback survey. To get started, you'll see the agenda on the screen. Today, we are going to have 3 guest presenters, Dr. David Attalla, Rachel Atkins, and Neda Nasseri. Also, we'll have a Q&A session following today's presentation. So at this time, we usually allow attendees to get familiar with the polling process by asking the following question, which you'll see right now on your screen. Question number 1, which stakeholder group do you represent? Is it A, insurance company, B, benefits consultant or broker, C, employer, D, pharmacy benefits manager or PBM, E, third-party administrator or TPA, or F, other? So once again, please make your selection and then press Submit. We want to thank everybody for participating. It's so helpful for us to get a feel for who is in our audience today. And we'll be closing the polling question in just a few moments. So we will see what our audience is made up of. There we go. Results are down, and it looks like the majority of our audience are benefits consultants or brokers. Yes, the majority. Thank you, everybody. There, we have one more polling question for you, and it is coming up on the slide. There it is, everyone. Polling question number 2. Do you believe all insurers, benefits providers, should cover anti-obesity medications as a standard inclusion in all their drug plans, instead of leaving the decision to the plan sponsor benefits advisor to opt in? So A, yes, B, no, and C, not sure. So again, please make your selection and then press submit. And thank you everyone so much for sharing your opinion on whether anti-obesity medications should be covered as a standard inclusion. We'll be closing the polling soon and find out what you say. Should be a couple more seconds, and there we go. The grand majority of you say yes. All right, thank you very much, everyone. We'll now start our session. So at this time, I would like to introduce you to our first guest speaker, Dr. David Attalla. Dr. Attalla is an internal medicine specialist and a fellow of the Royal College of Physicians of Canada with special expertise in metabolic syndrome. His special interests include diabetic care, polycystic ovarian syndrome, and exercise physiology. With a background in psychology, in addition to medicine, his focus is combining these expertises to offer patients updated, evidence-based medicine. A warm welcome to you, Dr. Attalla.
Thank you, Allison. What I'm going to talk today about briefly is a little bit about the state of obesity, basically, in 2023, what we're dealing with, and then what the options are for patients and how obesity may affect a patient throughout their life. So I think in order to take a step back and understand obesity and how it's reflected in the world and in the workplace, is to see it through the eyes of the patient who is, suffering from obesity or has obesity, right? And they have to deal with several things. Two of those large problems can include weight bias and weight stigma. Weight bias is the negative attitudes towards patients who are living with obesity. And this is something that we may have all heard of before. Oh, this person's lazy, or this person doesn't have good self-discipline, etc. These kinds of, biases or almost judgments that we put on people with respect to something like a medical problem, And then the second part is the weight stigma, and that's these stereotypes assigned to them. So whereas bias is a negative attitude, stigma is more the stereotypes. And I think in a survey, about 2/3 of patients reported that they feel some level of weight bias or weight stigma at work or in the workplace. And so this is a real problem that the majority of patients who are living with obesity deal with on a day-to-day basis. I think it's also important to go through the implications for obesity. I think that's another thing that maybe a lot of people are aware of, but it's important to review, is that obesity is not a simple problem of weight. Rather, the weight has the mechanical effect, but the adipose cells have inflammatory effects, and these two things combined can affect a lot of different organs in the brain, right? Obesity is a risk factor for strokes. Patients who are more sedentary have a higher risk of developing Alzheimer's disease. They can develop sleep apnea. They can have restrictive lung disease. The vast majority of ultrasounds I see today show fatty liver, right? I don't think I've seen an ultrasound that didn't show some level of fatty liver or hepatic steatosis in the last 6 months, because it's just so prevalent right now, right? And that's related to metabolic dysfunction. It can cause endocrine problems, whether it's polycystic ovarian syndrome, whether it's diabetes. It can cause issues with blood clots. It can cause increased risk of cardiovascular disease. It can increase your risk of acid reflux, et cetera, right? So a lot of these are issues that patients have to deal with on a day-to-day basis when obesity is present. And it's also important to know that it's not just affecting those symptoms, but it is affecting patients a little bit more directly. A patient whose BMI is over 30, they can expect a life expectancy decrease from about 2 to 4 years. A patient whose BMI is over 40 the first one was 30, 2 to 4 years for a BMI over 30. For a BMI over 40, the average life expectancy decrease is about 8 to 10 years. So we're talking about almost a full decade of life less when patients have a BMI of over 40, which really emphasizes the urgency in addressing this problem, right? It's that's why it's considered its own medical problem or a disease now, not just a risk factor, because it affects life expectancy very directly. Okay, I'm not going to get down too much into the details, but it is really important to understand that hunger and homeostasis are very complicated processes, right? Eating is not as simple as self-control versus lack of self-control. There are multiple hormones and neurotransmitters involved in the signaling of hunger, as well as the feeling of cravings. What you see in front of you is the diagram for homeostatic eating, but it's also important to remember that there's also hedonic eating, which is mediated a little bit differently. And hedonic eating is when it's more emotional eating. But this right here is homeostatic eating, as you can see, you've got multiple neurotransmitters and hormones coming from different organs, right? The stomach can release ghrelin. Adipose tissue releases leptin. The pancreas releases insulin. The intestines release cholecystokinin, glucagon-like peptide 1, peptide YY, and oxyntomodulin. And all of those go together and are interpreted in the hypothalamus. And then within the hypothalamus, different groups of neurons can forward that signal to mean different things, right? If the POMC nuclei are activated more, then our brain sends out satiety signals and we feel full. If the AGRP or agouti-related peptide nuclei are activated more, then we feel hungry, right? And as you can imagine, not everyone has the exact same levels of ghrelin, leptin, insulin, etc. But at the same time, not everyone has the same number of receptors in the brain or the exact same, pathway robustness, so that these signals can be interpreted differently. And there are several genes involved in terms of how people can interpret these signals, as well as the levels of these hormones, which is why genetics are very closely tied with obesity, but also why you can see a lot of families can sometimes look alike, right? And it's because of the fact that it's so complicated on multiple levels. When it comes to assessing patients who are living with obesity, it's important to, and this is more for physicians, but it's really important to ask the question. An interesting survey found that about 1/3 of physicians bring up weight to patients, while 2/3 of patients would like it brought up. And so it's actually a problem that patients are interested in addressing, but sometimes they don't feel comfortable to bring up. And so it's an important barrier to break as well, is to actually bring up the topic. But once a patient's come into my clinic, the first thing we do, of course, is the diagnosis and the assessment. Weight and BMI and waist circumference, those are all helpful. And the other thing that can be helpful sometimes is what we call the 4M framework. The 4M framework is a nice little checklist that can see the way someone's weight has affected their body. There's mechanical, which can include things like whether they have arthritis, back pain, sleep apnea, all again mechanical ways where it can affect the body. There's metabolic, so that can include things like kidney disease, diabetes, high blood pressure, high cholesterol. There's mental, right? Has their weight caused them any anxiety, any undue stress or depression? But also, do they have mental health comorbidities that are contributing to their weight, including whether they have attention deficit disorders or whether they have inopportune time, whether they have addiction disorders, etc. And then finally, there's social milieu, which is something that can include whether they have the income necessary to afford medications or to afford eating healthy and buying groceries, especially in today's climate, whether they have time to cook, and whether they have the skills or the knowledge to cook as well. And so these are all barriers that we identify on initial assessment that can really help categorize patients, but also gives us a nice reminder on follow-up in a year or two of things to recheck, whether it's their cholesterol level or to repeat a sleep study. When it comes to treatment, there's 3 main pillars available to us based off the health or the Obesity Canada guidelines. There's the behavioral and psychological interventions, and that can include things like behavioral modification, cognitive reframing, some strategies there, making sure to do our best to manage sleep time and stress, and then psychotherapy if available. You'll see there that managing sleep is an important part, but as a lot of you can probably predict, sleep and weight go together in multiple directions, right? When patients have little sleep, they can be more stressed, and sleep deprivation is associated with eating more as well, but also eating more and weight gain can then alternatively cause things like sleep apnea. And as you can imagine, that then becomes a vicious cycle. And so addressing each of those is really important, but it's also important to understand that the way they interact can make things a little bit difficult. And so sometimes you need a little bit more firepower to address something in order to push all parameters in a positive direction. The second pillar is pharmacotherapy. And the indications right now from Obesity Canada for pharmacotherapy include a BMI over 30 or a BMI over 27 with what we call adiposity-related chronic changes. An adiposity-related chronic change can include things like high blood pressure, high cholesterol, diabetes, sleep apnea, or steatotic liver disease, or what we used to call fatty liver. And so the evidence is there to show that those diseases or those processes can be reversed with weight loss. And then lastly, there is bariatric surgery, which is available in Ontario as well. And the indications are just a little bit higher. It'll usually be a BMI over 35, or if their BMI is over 30 with something like diabetes or other specific complications. To take them step by step, it's really important to understand that earlier therapy is best. Like what I was alluding to earlier, it's not just the mechanical part of the weight. It's the fact that adipocytes live in the body and are continuing to release inflammatory cytokines, and that adds up over time and time and time. And so the longer a patient is living with obesity, the longer those adipocytes or fat cells are living in the body, the more they have a chance to cause inflammation. And so that's why earlier therapy is better, because you actually end up having less damage to the body the earlier you intervene, which I think sometimes can come at a little bit of crossroads, because a lot of other things in medicine, there's sometimes a watch and wait mentality. That might be a better approach for some things, trying different things and then seeing what happens. And it is definitely important to use escalating care in obesity. You always want to try lifestyle first. I think that's an important pillar to understand, is that lifestyle first is absolutely still the recommendation. But it's also important to understand that if lifestyle does not succeed, the option to escalate therapy should always be there for a patient. The other thing to understand is that weight is not static, right? Most patients who, let's say, hit a BMI of 31, by the time they're 40, it's not likely their BMI is still going to be 31 in their 50s, right? Most people are on a trajectory, and it's rarely a flat line. So if someone is gaining weight and getting into that obese range, they're most likely going to keep putting on more weight and more weight and more weight as they age. And the more weight they put on, of course, the harder and the more distance there is to cover to come back down. And based off some limitations of today's, pharmacotherapy and surgery, if you're talking about 15% weight loss reduction or 40% weight loss reduction, it's really important to be addressing people whose BMI is in their low 30s as opposed to mid 40s, right? Because, someone who's 360 pounds, for example, 20% weight loss reduction is great, but it's not going to be enough to put them in that low risk category. It's better to catch them when they're in the low 200s or high 100s, depending on their height. In terms of pharmacotherapy, Obesity Canada currently recommends 4 different options. There's orlistat, which is Xenocol. There's liraglutide, which goes under the name Saxenda, but there's naltrexone and bupropion, which come under the name of Contrave. And then there's semaglutide, which is available or Wegovy. All of these are recommended by Health Canada. However, orlistat has kind of fallen out of favor. If you'll remember, earlier I was talking about the neurobiology and the neurohormones that affect obesity. Xenocol doesn't really affect those. And so we don't use it anymore. It was more for malabsorption, and it doesn't really work very well, and it causes a lot of different side effects. The other 3 are, again, liraglutide, which causes an average of about 5.5% weight loss over the span of about a year. Naltrexone bupropion, which causes about a 5% weight loss as well. And then semaglutide, which is closer to about 12.5 to 15% weight loss, depending on the dose. And so it's important to understand that these are approved by Health Canada for weight loss and recommended for weight loss as well in any patient who's tried lifestyle changes for about 3 to 6 months and has not had success. There is also the new clinical trial called SELECT. Some of you may have already heard of that recently. And that was an outcome trial for semaglutide but not just looking at weight loss, rather looking at the chances that someone is going to have a myocardial or cardiovascular event. And that could include cardiovascular death, myocardial infarction, or stroke. And what we saw in this double-blinded, placebo-controlled phase 3 trial was that patients have a reduced outcome of about 20%. So you're preventing 1 in 5 either heart attack, stroke, or cause from cardiovascular death by losing weight from medication. So here we see the very intimate relationship between obesity and cardiovascular mortality. And through reducing weight, we were able to also reduce cardiovascular mortality as well. And so that's a really important point, because I think a lot of the evidence so far has been to, use these medications and things like diabetes and reduce weight in diabetes. But these are patients that don't necessarily have diabetes. In fact, one of the inclusion criteria was an A1C below 6.5%. So these would be patients that are excluded from a lot of, programs to have these medications paid for. Their risk of heart attack and stroke was reduced by 20%, as well as all cardiovascular death. So it's another sign that points that it's really important to expand access beyond just those who have diabetes. Finally, there's the surgical data, and that was in a 2017 New England Journal study that found about 12 years after bariatric surgery in about 418 patients, these patients were basically maintaining an average of about 35 kilograms lost 12 years later, whereas they nadered at 45 kilograms lost the first couple of years. That did look a lot better. That they did regain a little bit more weight, but it still looked very, very good several years, 12 years down the line. So that's, obviously that's a very positive finding. But of course, surgery is a little bit higher of a barrier, and of course, the recovery associated with it is a little bit different. The other thing, of course, is that it's important to understand that right now there's almost a race to cover these drugs in some parts of the world. In the United States, the American Medical Association has basically urged the coverage of these drugs for everyone, right? Obviously meeting the criteria, but based, irrespective of plan. There was a survey recently that found only a third of payers are not considering paying for these drugs, whereas about 4 in 10 already do cover it, are actually closer to about 5 in 10 already cover these drugs. So about 50% cover them. About 20% are considering covering, but only a third are not. And then another article written by just last month talking about how GLP-1s and weight loss drugs in general are inevitable, right? Delaying coverage just accelerates health inequity. And then finally, there's an article that I wrote last year about this exact topic, but more so about, you want to save costs, cover these things up front, because ultimately a patient with obesity, right, throughout their life, they may need a lot more things than the average patient. And so and this is not even a comprehensive list, but as you can see, it's a pretty dense slide, right? A patient with obesity is more likely to need a sleep study, a CPAP, maybe an oral appliance for their sleep apnea, or maybe they try surgery. And surgery for sleep apnea is not always successful, but they can go through an entire algorithm of treatment just for something else that was, the risk was increased by their weight. They're at high risk of being sleepy even when treated for sleep apnea. So that's more CPAP titrations down the line, more frustration because the CPAP is not working, even though it is, but there's other things, going on as well. They may need a multiple sleep latency test. They may need more expensive medications that are used as stimulants in the future because they don't necessarily feel better by just treating the sleep apnea. They may need multiple liver ultrasounds, fibroscans, which is a type of elastography that's done every couple of years to look for steatotic liver disease or fatty liver. They're going to need more blood work to check for diabetes. They're going to need more blood work to check for high cholesterol. They're going to need more blood work to screen for fibrosis of the liver. They may need a 24-hour blood pressure monitor in their lifetime. They're more likely to need a Holter monitor, more likely to experience high blood pressure and consequently atrial fibrillation. They may need lifelong pharmacotherapy for diabetes, high blood pressure, high cholesterol, and fatty liver. Right now, there's antifibrotic agents coming in the U.S. for liver cirrhosis and liver inflammation. And so there's just more and more that they have to go through, right? More cardiac testing, more heart procedures, more pulmonary function testing, more medications for their kidneys, more chemotherapy and radiation, right? Obesity is one of the risk factors for a lot of cancers, and some cancers, especially breast cancer, is very strongly tied to adiposity because the more fat cells patients have, the higher their estrogen levels can be because adipose cells have this molecule called aromatase that can convert some inactive molecules into estrogen, which is a risk factor for breast cancer. Right? They're going to need more knee and hip replacements. That's more time away from work. They're going to need more rheumatology assessments. A lot of these patients may need, have their gallbladder taken out. So the health system is being used so much more frequently and so much more expensively. And these patients miss more time from work, and they miss more time from their families, and they lose out on so much by us just ignoring or not addressing the obesity as a disease. And it's important that we not only address it, but we address it with the full arsenal that we have available to us today, right? And the arsenal includes all three of lifestyle, medications if needed, if they meet the criteria, and then surgery for those patients where medications cannot be an option or are not tolerated or do not work well enough. And I think, if we offer that care and if we cover that care, we're just reducing so many downstream costs, and we're making life so much easier for them down the line. And so I think that's the main important point to focus on. And I appreciate your time today.
Thank you so much, Dr. Attalla, for sharing that super informative presentation with us today. So before we introduce you to our next guest speaker, we've got one more polling question for you, which is going to appear on your screen very shortly. There it is. Polling question number 3. How important is it to have a patient voice included when determining coverage for anti-obesity medications? So on a scale of 1 to 5, where 1 is extremely important to have a patient voice included, and 5 is it's not important to have a patient voice included. So please make your selection and press submit. And again, thank you everyone for participating. We're seeing your feedback on the importance of patient voice when determining coverage for anti-obesity medications, and we'll be closing our poll in just a few seconds. So the results are up, and the majority of you are saying, yes, it's extremely important to have a patient voice included, followed by people hovering in the middle. So, but the majority say yes. So there we go. Now I'd like to introduce you to our second guest speaker, Rachel Atkins. Rachel's career is based on a strong aptitude and passion for strategy. For more than 20 years, she's delivered solutions to drive large-scale business transformation. Now she's keen to leverage those experiences and exposures to transform communities, institutions, and society to better the lives of Canadians living in larger bodies. As someone who has struggled with weight management her whole life, Rachel was fortunate to find a welcoming community, gain access to evidence-based information, and tap into the care she deserves. She found her voice and is comfortable advocating for herself and is passionate about advocating for others. Rachel's vision and hope for our future is that we no longer live in a world with overweight, fat, or obese people, but rather there are just people living happy and healthy lives. Welcome, Rachel.
Thank you, Allison. And thank you to Dr. David Attalla. We need so many more of you. As mentioned, I am the Vice Chair of Obesity Matters, and I'm just going to take a few minutes to share with you the patient perspective. And I think it's very interesting that 42% felt that the patient voice was really important when we consider the coverage. And I feel very excited to hear the first polling results that 63% felt that these obesity medications should in fact be covered. So I just actually want to start by sharing a little bit about Obesity Matters. We're an organization that didn't really get established until about 2020. So we haven't been around for too long, but I'd like to say that we've already been able to make a big impact. Our vision, in fact, is to create a future of weight acceptance where health and happiness are the priority. Now, we do have a whole set of beliefs that we use to gauge against all of the things that we are doing and all the actions medications we're taking. But I thought it's really important to share these three with you. The fact that our ideal weight is not an absolute number on a scale, but really it's a weight that doesn't impair our health and does not negatively impact our life. And the next one is so important, and we have so much work to do in this space, but this concept of eat less and move more, it's just not enough. We have to do so much more to lose weight. And Dr. David Attalla really gave us a good understanding of how complex this chronic disease is. It's not just about willpower. And the final one I want to share with you in terms of an important value for Obesity Matter, no matter your size, shape, or abilities, you deserve interactions founded on respect, understanding, and dignity while having equal access to medical treatments and therapies. And as I'd mentioned, we haven't really been around that long, but we're already making a really huge impact with the community that we do have. We're hearing people saying things like, if motivation fails during a long journey, having a community like Obesity Matters who supports you no matter what is most helpful. These are the kinds of messages that we're hearing from our community, and the impact of the programs that we are running are doing things like driving policy change through advocacy, through some of the programs that we're running to do advocacy panels throughout the different provinces, just really helping patients also feel empowered to be able to advocate for themselves and their communities is really important in terms of seeing some of the outcomes of our programs. And as I'd mentioned, some of the programs, I'm actually part of a year-long free program for our community, which is a wellness workshop that runs live every 2 weeks. And we are bringing experts like Dr. David Attalla right into the living rooms of the individuals that are part of our community and supporting their needs. We're running a policy roundtable. We've started in Ontario. We're looking at doing so in Quebec next. We now that we're allowed to have in-person events again, we are looking to hold the second Your Health Matters Summit, which is an all-day hybrid summit. We started last year was our first one, and we're looking at doing another one next year. And we have great connections within the media, which really helps us to amplify the voice of our community. And so, as I'd mentioned, there's a whole series of different types of things that we're working on. And we're also helping to drive traffic to some of the clinical trials that are happening right now, and continuing to make sure we're putting a big emphasis on our social media campaigns. So, as I'd mentioned, I want to share a little bit with you about some of the stories of the individuals in our community. And let's start with Angela's story. And I thought the best way for you to hear her story was to watch this little video clip.
So your speech today was wonderful, and I feel like I'm the poster child. When you talk about obesity, I'm the poster child. I'm not alone. I've had conversations with lots of friends and people I've connected with. I'm a nurse, so I've worked in primary care, and I've seen people have the struggle, so I was able to attend a lot of sessions and information sessions about this sort of stuff. And then even myself, I decided to take a program. I've been involved, you name it, Weight Watchers, TOPS, keto, non-keto, Dr. Atkins back in the day, you name it, I've done it. And I've had a lot of really compassionate people in my life, like compassionate providers like yourself who have, sympathized, understood. It's been my story. Everything you've said has been my story. Yet here I am, still trying to find the answer. So here I come in here and I'm like, yes, acceptance is the answer. This is what I'm trying to promote now, because I'm like, clearly I can't do it because I don't have enough values, motivation, all of these things just makes complete sense to me, right? Just making this up as I go. So I'm like, here I am, what do I do? What does someone do in my position? You want to get healthier. And so my doctor recently prescribed me Desjardins, which is on your list. Desjardins and Saxenda are like these two, and Ozempic is another one that's up there as well. I know I've done my research. A lot of people out there in this industry just want to make money from it because it is a cash grab for a lot of people. So where do you get good information? Where are you getting all this stuff? So Jardiance has been sitting on my nightstand for 2 months now, and I'm reluctant to try it. And I said to my doctor, what's it going to do for me? He goes, oh, it'll help you with the cravings, he said. I said, well, how much can I expect to lose? He goes, well, you can lose 10 to 15 pounds without even trying. I'm like, wow, significant. Thanks for the help. That means nothing to me, right? Like, I'm not looking for the right answer. I'm not looking for anyone to give me the solution. But there are other big problems. This is all, like, we're all here for the same reason. And, you can stop the advertising and you can promote all these things. And where do we start? Like, let's get it started. But, I see it every day. I see it in my relationships. I see it in my friendships. I know what I go through. So if I feel like I've sort of, been there, done that, what's different today?
So we are very fortunate to have people like Angela in our community that are courageous enough to share her story. And we're also very fortunate to have people like Dr. David Macklin, who you saw in that video. And his response to Angela was, in fact, to apologize on behalf of the medical community and to also share that acceptance is a really important step. But treatment and fair access to treatment is really what's going to make a difference in improving people's lives. So that's a really important consideration. And we thank people like Angela. And, we have a significant number of people in our community that share Angela's story. And so what we've done is just to sort of say, like, let's think of a fictional character like a Georgie. She's very representative of a lot of folks in our community, a 50-year-old single mom of a teenage daughter. She's a manager in the auto industry, so she's got a demanding job, lots of travel, late nights at the office, and decades history of yo-yo dieting and trying every fitness class out there. She happens to now be a person that's living in a larger body and also at that age of menopause and feeling the aches and pains of aging. So what you'll see on this chart is that little faint line in the background, and it's very typical of many of our journeys. There's a lot of highs and there's also a lot of lows. And on the top end of the spectrum is that weight gain where, unfortunately we find ourselves in situations, can't fit in our clothes, ankle pain, sleep disruption, stress, and really a lack of focus. And then on the bottom end is where we start to see, some weight loss, maybe some improvements in our health. In general, better focus, more confidence in ourselves, and more time for less fun and less joint pain. So over time, you can see that, we kind of straddle within these two lines. And at some point, we also get to experience some weight stability. But really, I just want to share a couple of highlights from this journey, and Georgie starting out thinking, I want to seek help to be healthier, stronger, a better role model for my daughter. And then she's fortunate enough to have access to a doctor that helps to guide her in the right approach, and it is really important that we look at things like lifestyle considerations, and then perhaps some cognitive behavioral therapy before you get to that conversation around medications. And when that happens, that's for the individual that has to make that decision for their life. It's a tough one. These medications are very expensive. And also, it does take a lot to accept the fact that these medications are also something you have to take for life. So these are important decisions to make, just to even say, yes, I will take that medication. And then, then you start to see the great side effects like, cravings going down. And perhaps you might even see some weight loss. And that's not necessarily just the end goal, but other things like being able to focus on other things in your life, focus more on your work, focus more on the relationships that you have in your life, like Georgie spending time with her daughter. And then what we're hearing now over and over in our community is that there are some people that are finding when they've made these decisions, they're moving forward, they're making the sacrifice in their life, because a lot of times they have to make the sacrifice to be able to pay for this medication and perhaps not pay for something else that's important in their life. Then they're finding that they're getting to the pharmacy to renew their prescription and the medication's not available. And then, they go a couple of weeks and they haven't been able to take the medication, and the cravings start to come back. Perhaps, unfortunately, the weight starts to come back, and they make a decision that, okay, actually, I'm going to take these funds, put them on something else that's important in my life. And they are then outside of this cycle of taking medication to improve their health. And that's a really unfortunate place to be. But we're hearing this story over and over again. And so what's a not so great ending to this story is, as Dr. David Attalla has explained to us so eloquently, obesity is a chronic condition and it may not be covered by insurance. Not all insurance companies cover that, unfortunately. And in many cases, someone living in a larger body, it's not necessarily their fault. There's a lot of other complicated factors that play into that. But unfortunately, when things like the fact that it might not be covered, an anti-obesity medication may not be covered, it kind of feels like, blame on the individual. We don't really believe that this is a chronic condition that's outside of your control, so we're not going to cover it. And then, also we know, and this community now is very educated. We all know that obesity, unfortunately, leads to many other chronic conditions. And when your health is impaired, it affects you as an individual, it affects your family, your community, and society at large as well. And that's the not so great ending to the story. There is a better ending to the story, though. And I would say that you all have a role that you can play in this. And that starts with the medications are covered. And instead, at the end of Georgie's story, she joins the wait list. And when the drug companies are able to restore the supply that we need, it is available to her and it is accessible. There's no reading between the lines, right? And insurance companies are walking the talk. They're here to put together programs that better support healthy lives for individuals, for employees, for their families. There are choices also. We need to have different choices. One medication may work for someone, and while it doesn't really work for another person. So we also need to have choices. But the one thing Dr. David Attalla also pointed out is that it isn't really important for these medications to be accessible for everyone. Period, full stop. Particularly marginalized communities, it's really important that these medications are available to everyone and accessible. So, it's a simple formula in my mind. Obesity treatment is available and accessible. The chronic disease goes down. The physical health goes up. We, in general, have better mental health, better well-being. Costs go way, way down. This is the story that we want to be able to share. So thank you for allowing me a little chance to give you a glimpse into the patient perspective. Again, Obesity Matters is an organization that we started back in 2020. We have a wonderful list of partners that are helping us in this movement to build a better future. And my ask of you would be that in every decision that you are making around coverage, what kinds of packages are you presenting to employers? You are thinking about this patient perspective. You're thinking about Angela, Georgie, myself, the whole Obesity Matters community. Thank you.
Rachel, thank you so much for your passionate and thought-provoking presentation today. Before we introduce you to our final guest speaker, everyone, we've got one more polling question for you, and it is on the screen right now. Polling question number 4. What do you think is the most significant reason to add obesity benefits to an employer-sponsored benefits plan? Is it A, support diversity, equity, and inclusion initiatives, DEI? B, employee attraction and retention? C, increases productivity? D, helps to avoid a portion of other medication costs? Or E, other? So if you select E, please press submit and then enter your response into the Q&A box, if you could, please. I'm just going to move my slides over so I can see Here we go. We'll wait for the answers to come down. There we go. And it looks like the majority of you chose D, helps to avoid a portion of other medication costs. And again, if any of you chose E, if you wouldn't mind, if you could add your insights into what you think in terms of other solutions, please do let us know in the Q&A box. Okay. Wonderful. So now I'd like to introduce you to our final guest speaker, Neda Nasseri, a healthcare innovator by day and organizer by night. Neda strives to make healthcare more accessible, equitable, and affordable. She's a pharmacist with experience in both community pharmacy and in the pharmaceutical industry, notably in biosimilars and diabetes. Currently, Neda works in the private payer sector at Desjardins Insurance as a product director for drug benefits. Neda has always been very passionate about learning, earning a master's degree in pharmaceutical sciences, as well as a master of business administration with a specialty in marketing and ethics. We want to welcome you, Neda.
Hi, hello everyone. Thank you very much for introducing me. I hope you guys can hear me well. I've caught something today, so I will not be on camera. I will spare you that, and I've heard viruses can be contagious through the screen. So I saw the answers that you guys gave for the polling, and hats off. I'm not even sure I need to present this, so but here I go anyway. So in our fight against chronic disease, Desjardins Insurance is partnering with leading organizations. For example, we're the only insurance company to actually have an ongoing partnership with Obesity Canada. And that's the country's first not-for-profit organization, and they're dedicated to improving the lives of Canadians through obesity research, education, and awareness. And as mentioned previously, we're also partners with Obesity Matters. And Rachel very well described what their mission is. So this is a testament to our commitment to bettering the lives of our insureds in all shapes and forms. As an insurer, our clients are the plan sponsors, also known as employers. So if you are not an employer, let's pretend you are for the sake of this little experiment. So look at this picture. Both candidates have the same skills and are interested in working for your organization. Who would you hire? Some of us choose the slim candidate. Some of us may even feel guilty about it to a certain extent. Others may not. But many of us have misconceptions about weight gain. Maybe we criticize people for being overweight. Maybe we look at what they're having for lunch, or if they're taking the elevator instead of stairs. All these weight biases can lead to discrimination in the workplace. In fact, Dr. Attalla mentioned it earlier as well. 54% of adults with obesity said they were stigmatized by their colleagues, knowingly or not. So what that means, words and actions actually do have an impact. Not only is there a personal cost to people living with obesity, but there's also a healthcare cost to all of us, to our governments. In 2021, health costs directly related to obesity reached $9 billion in Canada. And in 2022, around 30% of adults aged 18 years and older, well, yes, that is the age of an adult, right? In Canada, were living with obesity, while 35% of them were overweight. That is about 2/3 of the population. And again, like Dr. Attalla was referring to, when we think of obesity, we automatically think of BMIs that are higher than 35 or 40. And it's very easy to have a BMI higher than 27 or 30. Just ask a woman who has given birth. So everyone is touched by this disease. If it's not you, it's your parents or your best friends or even your employee. In fact, obesity is associated with high indirect costs for employers as well. According to a retrospective analysis in a large national employer database, employees with obesity-related complications were nearly twice as likely to file short-term disability claims. The same study showed that employees with a BMI higher than 40 tend to miss 77% more workdays than the employees with a BMI of 25. And additionally, presenteeism in the workplace has been shown to be the single largest cost driver. So something needs to be done for employers as well. Studies have shown that 5 to 10% weight loss leads to about 58% reduction in the risk of type 2 diabetes, in a reduction in heart problems. The SELECT study showed it too. A decline in joint disease and pain, and also so many more benefits. But I don't want to insist so much on the weight loss, but more on regaining health. It's not only beneficial for an employee's life, but also for an employer's drug plan and disability plans. Healthier employees rhyme with less expenses for the plan sponsors, and these expenses can be reinvested into other services for employees. In order to support our plan sponsors, Desjardins put together the Healthy Weight Initiative to address the different pillars that Dr. Attalla told us about. But this really didn't come overnight. This timeline shows you what we did in support of our insureds. In 2015, we started having our discussions. We looked at what tools were available to us, at the resources online. And in June 2019, we launched Phase 1 of the Healthy Weight program. In June 2020, we announced our partnership with Obesity Canada, and we've been working hand in hand with them, looking at the research and working on awareness. And in August 2020, the new obesity guidelines were released. Finally, obesity is considered a disease officially by Canada. So in October 2020, we started having our internal discussions, and actuaries are very hard to convince. So it went on and on and on until August 2021, when we decided to include standard drug coverage for obesity for all our new groups. And then in 2024, we will do the relaunch of the Healthy Weight Initiative. So basically, we added these as our standard offer in 2021, and as a result, close to 50% of our groups include coverage for obesity medications now. And that is a winning strategy to have a healthier workforce. The Healthy Weight Initiative is part of a holistic approach aimed at changing habits and behaviors and improving health, as well as facilitating activities of daily living by addressing the subjects from all angles possible. Our offer includes coverage for the combination of drugs for the treatment of obesity and healthcare professionals to accompany people on that journey. So there's dietitians, of course we know what they're for. There's psychologists, and we have a very high maximum for them. That's what we recommend anyway. We give coverage for kinesiologists. Those healthcare professionals, they allow individuals to train in a safe environment. And also ergonomists. That, what they do is basically to make people more comfortable in the workplace. Plan sponsors can basically configure their plan according to what they wish to offer their employees by selecting the categories of healthcare professionals and drugs covered by their group insurance plan, as well as the associated amounts. As part of the Healthy Weight Initiative, in the new year, Desjardins will provide our plan sponsors with a best practice guide in order to welcome comfort and acceptance to employees living with obesity. Also, in order to embrace diversity and inclusion, to lower risks of stigma and discrimination in the workplace, and hopefully increase employee retention, because when you feel good somewhere, you don't want to leave. In summary, how can employers be part of the solution? By making sure that their benefit plan offers coverage to all the treatments recommended by the Canadian Guidelines on Obesity. You can see them on the left. And at Desjardins, we pride ourselves on following these guidelines, as we want to make sure, for our plan sponsors' sakes, that our insureds live happy and very healthy lives. So what are our take-home messages? Well, that insurers have to consider obesity on the same level as any other chronic disease. And people living with obesity have a right to be treated for their disease. It's only ethical. Obesity treatment saves lives now. We've seen it in the results of the SELECT trial. Employers can actually help their employees by offering coverage for dietitians, kinesiologists, psychologists, and of course, medication. And finally, employers can make their workplace safer and more inclusive. Thank you very much for giving me the opportunity to present our program.
Thank you, Neda, for your excellent presentation. Before we move on to the Q&A period, everyone, we've got 2 more polling questions for you. Here is our next question. You'll see it come up on the screen shortly. Question number 5. Which other services would you value for obesity management? Would it be A, kinesiology or safe exercise therapy, B, psychology, C, dietetics, D, alternative medicine, E, wellness program, F, all of the above, or G, other? And again, if you select G, if you could press submit and enter your response into the Q&A box about other services you're thinking about. That's for people selecting G. And also, as many of you in the audience are benefits advisors, we're really curious about what services you feel your employer clients and their plan members would value for obesity management. So please do let us know. And the polling will be results will be coming down very, very soon. Wonderful. And the results have just come up. And the majority of you by far are saying F, all of the above. So fascinating. Thank you for sharing that with us, everyone. And we're going to move on now to the final polling question. Question number 6. What are the main challenges or roadblocks that prevent advisors from proactively discussing inclusion of anti-obesity medications with plan sponsors? Is it A, lack of time, B, competing priorities, C, need for more tools, resources, and education, D, limited plan sponsor interest, or E, other? Again, if you choose that, press select and then type in your response into the Q&A box just to give us a little more context, please. Once again, thank you everyone for participating. We should be getting our polling results coming up very, very shortly. All right. And it looks like the majority of you are citing limited plan sponsor interest, followed by a need for more tools, resources, and education. So thank you for that, everybody. Those insights are very helpful to us. And at this time, we'd like to begin our Q&A period. So if you've not already done so, please submit your questions now. And to do that, just go to the Q&A panel, type in your question, and then click submit. And we are running short on time, so we're going to go straight to the questions that have come down already. And Dr. Attalla, we're going to start with you. Is BMI still the best measure to assess obesity, or is it outdated?
Can you hear me? Can you hear me?
Yes.
There, we can hear you now. Yes.
The answer is both. Unfortunately, so it's not outdated per se, but we do find that it's not a very culturally accurate representation of the risks associated with excess adiposity. We do find that there's a cross-cultural difference. For example, patients from certain parts of the world, they start to develop the signs of insulin resistance as well as other comorbidities at lower BMIs, closer to 25, 26, etc. So in that sense, it is a little bit outdated, but at the same time, we don't have like a perfect way of having different BMIs for every ethnic group yet, because we don't have enough data. But yes, that whole cutoff of 30 really only applies to white males. But it's what we have for now, and it's what the standard is for now. Is it the best thing? In an ideal world, we're checking waist circumference and we're checking neck circumference for most people, as well as hips, and we're doing a kind of like a dirty body fat percentage using those measurements. But realistically, clinics don't have the resources to be doing that, and workplaces should definitely not be doing that. So it's what we have because it's easy to do and it's quick, right? It's just a height and weight. You plug it into a calculator and you do it. It is not the best, obviously. In a clinical setting, you can probably do just a little bit better with waist circumference, at least, in relation to height. But not a lot of clinics do that, and so that's not likely to make it into guidelines. It's always recommended, but realistically, cutoff will probably always be related to BMI because of the fact that BMI can be obtained more easily. So I mean, I hope I answered that. It's both. It's outdated a little bit, but it's the best we have right now.
Yep, that's excellent. Thank you. Neda, I have a question for you. Are obesity drugs covered by public plans? And if not, why not?
Thank you, Allison. So, no, they are not covered by provincial plans. In Quebec specifically, I know that there's an exclusion for obesity drugs, and there's a lot of lobbying being done to exclude that. And in other provinces, we've been doing some work along with Obesity Matters to try to change this for the patients, because bottom line is, again, as we all exposed it, there's going to be a lot of negative consequences to not treating obesity. Even if you don't see it today, you're going to see it in 10 years or 15 years from now. So it would be amazing if we can have the ear of all of our deputies, and if you really believe in it, please go ahead and write something to them to let them know that you believe in that and that these should be covered, because it is not ethical to exclude a class of people from having good treatment for their disease.
Yes. And our last question is for you as well, Neda. It asks, cost of benefits is under assault from all directions: disability claims increases, expanding drug coverages, dental fee guides, and more. Who really is paying for all of this? Employers resist cost increases, saying enough is enough.
Oh wow, that's a hard one. Who pays for that? Well, at the end of the day, we do have cost containment measures as an insurer, so there are ways for us to pay less for drugs, not so much necessarily for dental guides, I would say. I'm not the expert on dental, but for drugs, there are ways to pay less. There are negotiations that can happen with pharma companies. Honestly, like, if you are to cover obesity drugs, and I'm gonna tell you this in all transparency, in August 2021, when we decided to cover all our for all our groups the obesity drugs, we did not see any increase of claims for obesity drugs. The only thing that happened is after the media meddled in this, but before that, I mean, all these drugs existed. Before that, Contrave existed, Ozempic existed, even though it wasn't officially indicated for obesity. Saxenda existed, but we hadn't seen any crazy increase. So I would say that physicians tend to prescribe responsibly, and if someone is prescribed that drug, it's really because they need it. And today, yes, it might be a little increase in your cost, but then down the line, you will be seeing the decrease in cost and disability, as well as in drug costs in overall for other diseases. So I think it's really, really important to look at ourselves, to look at our neighbors, and see how many people need these treatments, and then act upon it.
Yep. Thank you, Neda. And thank you very much, everyone, for the discussion today. And as we approach the end of the webinar period, we're going to conclude the Q&A session now. And if we were not able to respond to one of your questions today, or if you have any additional inquiries, please feel free to email us directly. Our email address is on the screen right now. It's info@maple.ca. We'd like to thank our guest presenters today, Dr. David Attalla, Rachel Atkins, and Neda Nasseri. We also want to acknowledge sponsorship of today's webinar by Obesity Matters, with support from Bosch Health, Novo Nordisk, and Desjardins Insurance. Today's webinar is part of the continuing series offered by Maple. If you're not currently on our email invitation list, you can submit your contact information by clicking on the View button in the links panel under Join the Maple Webinar Invitation List. We have a number of webinars planned for early 2024, so please stay tuned as email invitations will be sent in the coming days. At the conclusion of this webinar, a brief survey will pop up in your web browser. Please take a few seconds to give us some feedback. We always appreciate it. Lastly, CE certificates submitted to the Institute for Advanced Financial Education will be issued within a few weeks' time. So please let us know if you require a CE certificate in the feedback survey. Thank you, everyone, and have a great holiday, and we'll see you next year.